So we are bang on time for our next upcoming session. And I would just introduce all our chairpersons once again. Dr. Shashikant Shetty, Dr. Ramesha, Dr. Nikhil Rishikeshi, Dr. Lobsang Sentim, and Dr. Aditya Sethi. So these are our chairpersons who are going to chair the session. I believe we have only Dr. Aditya Sethi. So Dr. Aditya Sethi, could you please take this session forward and invite our first speaker?
I think good afternoon, everybody, and I think this is a wonderful place to meet right now, the virtual method, and AIOC 2021. We have a very nice list of speakers and a very important talk scheduled now about refractive errors in amblyopia management, which is essentially the essence of pediatric ophthalmology. Without delay, I would request the first speaker, Dr. Renu Grover, to speak on refraction in children. Over to you, ma'am.
So can you see my screen?
Doctor, you're perfect. You can, or you're all ready to go.
All right. So I'll be talking about refraction in children. So I'll begin by showing a short clip video. So this is just to show how challenging or frustrating it is to do a refraction in a child. Not to deter anybody, but we just have to change a few tactics to be successful in our pediatric refractions. So what are the challenges of pediatric refraction? First of all, there is inability to get an accurate or reliable visual acuity. Especially the pre-verbal children or even the verbal ones are unable to give an accurate visual acuity. So we cannot rely on the subjective refraction. Also, there is a variable control of accommodation. Smaller the child, the more is the accommodation. And the presence of strabismus is another challenge in which we are unable to get a good refraction if you're not thorough with it. So all in all, a great expertise is required. More than expertise, it's more of an experience which is required to do a pediatric refraction. And a lot of our postgraduates, graduates, when they begin, they just come up with the thing that the child has been uncooperative. So the word uncooperative is not acceptable in the pediatric ophthalmology. All children are uncooperative. You have to go around them to get the work done. For pediatric refractions, especially in the UK and over at our hospital also, we do 2 checks, either by 2 optometrists or by an optometrist and an ophthalmologist because most of this is objective, and we have to be sure before prescribing that we are close to the actual number. So when we get started for refraction, what are the things that you need to look at? So you need to, it's not like an adult refraction that the adult is able to tell you everything. You have to prod on to see what you are looking at and how you need to deal with it. So you need to have a good history of any surgeries, whether the child is pseudophakic, aphakic, whether he's had an ROP laser. Are there any developmental delays? Is it a Down's baby? Are there any neurological symptoms? All this is important because it also helps you in choosing which cycloplegic you use. In neurologically symptomatic children, we do not use cycloplegics like cyclopentolate. So that is why all this is relevant. Also, as and where you can take the visual acuity according to the age appropriate charts always helps, but it's not essential, but it always helps. You need to at least try taking a visual acuity and a thorough eye examination, if possible by a slit lamp or by an indirect, to see the anterior segment. There could be anterior segment dysgenesis. So if you already have this, you're good to go. At least you're mentally prepared what you need to be looking at. So all this, every child who has a refractive error need not be given glasses. So we have to be very careful to really show that if whether the glasses are indicated, what is the benefit versus the burden. So what is the aim of our refraction? So the aim of our refraction is to see if the child's visual system is developing normally. As you know that a child or a newborn is largely hypermetropic and it moves towards emetropiazation and go on to myopia. So we need to know the normal system to know that, how it is going to progress. And you have to compare the refractive status of the child according to the age norms. So if you know that a 1-year-old child may have a hyperopia of +1, +2, +5, but it's not, you don't have to prescribe that in a 1-year-old child, unless there are other conditions like squint. So then you have to correct the emetropia as and where it is required and allow the child to achieve maximum visual acuity. So just a brief thing about emetropization. As you know that the eye is hyperopic to begin with, and it goes on to normal axial length where the rays are focused on the retina, and later on may have a myopic shift. So these are the factors which influence emetropization. It could be genetic, like if the parents have a high refractive error, or the visual input, the peripheral retinal defocus. This is there's a lot of research going on this. The outdoor activity, the accommodation, and even low birth weight. So this is just a graph to show that newborn child is largely he can have plus numbers, whereas in 6 to 8 years it's nearly zero or emetropia. So development of refraction depends on the cornea, the lens, and the axial length. So you also need to know a little bit of anatomy, that the axial length in the newborn is 16.8, and in adult it goes on to 23. So you just need to know the basic, how things are progressing, and just not rely on the refractive error, what you're getting and prescribe. So how do you start doing the refraction? So as I said earlier, it has to be largely objective and not dependent on the patient's response. Autoref is the easiest thing to do, but you can't do it in a small child. It can be used reasonably successfully in older children, but certainly not in younger children who cannot focus on a target. So you see, this is a 13-year-old child, and he's focusing on the target, and we can get a reasonably good autoref reading, and later on do a subjective refraction to a certain extent and prescribe classes. But retinoscopy is what we largely do in children. It's the most useful technique in determining the refraction of the child. It's the most invaluable tool in experienced hands. And it not only determines the refractive error, but you can also know whether it is a regular or an irregular astigmatism, and you can also look for opacities in the media. A lot of keratoconus patients are picked up on retinoscopy itself. So this is really an invaluable tool, which every ophthalmologist, I think, should know how to use. Especially in pediatric ophthalmology. I mean, it is you cannot do pediatric ophthalmology if you don't know how to use a retinoscope. So this is one of our optometrists. She's doing an over refraction in a child. So what are the things that what are the retinoscopy tips to use in a child? So you use a lens rack where the lenses are stacked, and you have very little time to have the child's attention. So you have to be very quick about it. Or you can hold individual trial lenses in front of the eyes. Pediatric trial frames can be used only in older children, and full aperture trial lenses are preferred. So this is a retinoscopy rack where you have these lenses stacked up. These are the plus lenses, these are the minus lenses, and you can just move them up and down. It hardly takes a minute, and you at least get an idea whether the child is hyperopic or myopic or astigmatic. So it's very quick and very handy. These are the methods of retinoscopy, a dynamic or Mohendra technique. These are basically done for looking for accommodation, but in our setting, we usually do a cycloplegic refraction. Yeah. So cycloplegic refraction is carried out in all new patients, and especially there is a suspicion of poor vision, unusual blinking, rubbing, watering, recurrent chalazion stye. This is what this is the most common, sort of symptom that we encounter. Do not ignore it. Do refraction. The child may be having a refractive error. and of course, squint or a large exo or esophoria, or if there's a family history of squint or high myopia, high hypermetropia. I can't finish.
I think they take it off if your time is beyond.
Oh, can I
Yeah.
not extend by a minute?
Doctor, we are totally time bound today.
Okay.
So if you can just give us a conclusion, please.
So to conclude, I would say that retinoscopy is the most important thing in the pediatric refraction, and every ophthalmologist should know how to use a retinoscope. And you have to have a lot of patience to do it. And you should not prescribe glasses in any kind of a refractive error you're getting. You cannot. There is the next speaker is going to be talking about prescribing glasses. She'll tell you in detail, of course. But you have to look at so many factors to really prescribe glasses. Yeah, that's what I would really stress upon retinoscopy for refraction in children.
Thank you so much, ma'am. That was a very, very nice talk. And we all know as pediatric ophthalmologists how difficult it can be and how a few tips and tricks makes it so easy, especially with the pre-verbal children. I think the next talk is by Dr. Bhattacharya. She's going to be talking about prescribing spectacles in children. Over to you, ma'am.
Am I audible?
Yes, ma'am.
Yes, we can hear you and see the presentation.
Right. 1 second, I'll just. So let's move on to a beautiful topic, which is the bread and butter of all pediatric ophthalmologists, which is prescribing glasses in children. My first slide is of my son, which is to show that not only am I the doctor, but I'm also the parent here, a parent whose child has astigmatism and wears glasses. Therefore, the talking points of my talk will be, why do we need to prescribe glasses in children? How do we exactly examine children for refractive error, which was already covered by Dr. Renu? When do we prescribe glasses? How much do we correct? Do we undercorrect? And points to consider while choosing spectacles for children, because giving spectacles to children is not just a science, but it is the art as well. So this is where the art comes in, is how do you prescribe the spectacles? How do you counsel the parents? When do you change the prescription? How do you increase spectacle compliance in children? And how do we prevent bullying in children with glasses? So why do we need to prescribe? Of course, there's fear of amblyopia. There's a worsening of heterotropia or heterophoria, and children absorb information and learn both language and skills visually. And therefore, there's a fear of global delay, and that is language skills as well as other skills because of poor vision. How to examine a refractive error, we've already covered. So there's dynamic or dry refraction, which is also important in children. We tend to we definitely must do a cycloplegic refraction, and that is where the crux of prescription lies. And cycloplegia, either by atropine, homatropine, cyclopentolate, or tropicamide, whatever works for your type of practice. I prefer to give homide or homatropine instead of cyclopentolate, because a lot of my children are from they have fits and seizures, and I prefer to give homatropine. The other thing is serial refractions is what I would like to stress upon. That is serial refractions every 3 months under the age of 3, and serial refractions every 6 months from 3 to 6 years of age. And at each examination, check for amblyopia, check for refraction over the glasses. That is, the child is wearing the glasses and you refract over it with your retinoscope, and alignment for near and distance, wearing with glasses and without. So when do we prescribe glasses? Again, this is a lovely study by Liet S.J. et al. And here they've really asked some pertinent questions, which we all should ask ourselves, is that, is the refractive error within normal range for age? And which we already saw in our last study, presentation, that there is a huge range, especially in very young children. And these children are also unable to express their poor vision or blurred vision, or the fact that they can see better. So therefore, this normal range should be taken into account. Also, the fact that the visual system is a developing system in them. And so there's a chance of emmetropization at the young age, under 3 especially. Now, will the refractive error disrupt normal visual development, and also the difference between visual function, which is your normal Snellen chart or Lea symbols, and functional vision, which is how do they study, how do they move around, or what kind of activities can they do? And while prescribing, is there a heterophoria or a heterotropia? That is there a squint? And if they are aphakic or pseudophakic. Now, this is a chart which is mostly preferred by Indian ophthalmologists. This is the chart by American Association of Pediatric Ophthalmology. What I want to really stress upon is that this is preferred practice patterns, and these are guidelines. These are not set in stone, and it also depends on a lot of other points. So here we've seen when would you prescribe myopes, when would you prescribe hypermetropes, and anisometropy and astigmatism. Those are your different columns, and your rows are according to age. And as you can see that when the age is low, you want to hold a higher threshold for prescription, meaning you will not prescribe each and every number. Your threshold is high. And as the age increases, your threshold of prescribing lowers. So how much do we correct? This is a very basic chart. Take-home messages: if you're giving to an aphakic child, full refraction especially, plus near addition at infancy, and bifocals after the age of 1. Pseudophakics could be bifocals and progressive. I prefer progressive. In esotropes or esophoria, full cycloplegic correction. In exotropia, correct the myopia and undercorrect hypermetropia. And children are better able to tolerate anisometropia and anisokenia at this age. Of course, we saw this in the last session as well, that there was a lot of talk between binocular vision as well as anisometropia and anisokenia. But what is important a little over is also amblyopia. So I would go as far as to say 3 to 5 diopters difference is also well accepted by children, but the best is to keep it under 3 diopters of anisometropia. This is esotropia. You want to give full cycloplegic refraction, and if you're giving bifocals, prefer to give executive or flat top or D segment bifocals. In exotropia, if the child is hyperopic, then subtract about 1 to 1.5 diopters, and if it is a myope, give full cycloplegic refraction, which is still the lowest minus, and try to see if you need over minus if you're not going for surgery. Now, choosing spectacles for children. This is really important because your compliance to spectacles totally depends on this. You may write, you may do a brilliant refraction, you may give a very perfectly balanced evidence-based refractive error correction, but your child may not wear glasses if you don't give the right type of spectacles. And so here are a few points. That is, choose the correct frame size. The higher the number, choose smaller frames because there's lesser higher order aberration and the lenses are thinner. My last slide will be on spectacle compliance, and spectacle compliance depends on poor awareness, spectacle related compliance defects, psychosocial and financial barriers. And these are some of the solutions that are prescribed. And there's a beautiful study by Anuradha et al., which shows that these solutions actually work. Bullying and counseling. For counseling of children, ask about counseling at each and every session that you have with your child, that if they are being bullied, they may not open up to the parents, but they may open up to you as doctors. And counsel the parents at every session about guilt, shame, and blame on television and diet habits. And social education talks in schools as well as social media is important by doctors. Each doctor is an influencer. Thank you for your patient hearing.
Thank you so much, ma'am, for that very informative talk. I think the last two slides sort of suggest that how updated we have to be, not just as doctors, but also as parents and human beings. And we need to know all the new cartoons. We need to get them their attention. And
Yes.
them 3 or 4 months and keep checking their e-metro privilege. So without much delay, we're going to have the next speaker. Dr. Sahu is going to speak on amblyopia management.
And also, I would like to take this opportunity to acknowledge the presence of our chairperson, Dr. Nikhil Rishikeshi. Sir, you're welcome.
Thank you, sir. Thank you, sir.
Most welcome.
So good afternoon, everyone. It's an honor to share the podium with the stalwarts of pediatric ophthalmology. I'm Dr. Jigyasa Sahu, and I'll be speaking about amblyopia patching techniques. So occlusion of the sound eye is the most effective treatment of amblyopia. Occlusion is still considered the gold standard for amblyopia therapy. When fixation is central, occlusion therapy is simple and effective. However, when fixation is eccentric, only less than 7 years, central fixation can be recovered. The success rate of occlusion therapy is 30 to 92%. Mechanism of action being prevention of the fixating eye taking part in action of vision and removing the inhibitory stimulus that arises from stimulation of the fixating eye. So various types of occlusion have been described in literature: total or partial occlusion, conventional or inverse, full-time or part-time. But most of the data on response according to daily dose of patching are retrospective and uncontrolled. So in total occlusion, all the light is prevented from entering the eye. It is employed in amblyopic eyes with acuity less than 6/24, and occlusion is done using elastoplast, gauze pad, tape, or Doyne's rubber occluder. In partial occlusion, we do not cut off the total light entering the eye. We just degrade the vision of the normal eye such that amblyopic eye gets a better vision and preference. By convention, we occlude the sound eye always, but in case of inverse occlusion, the occlusion of the amblyopic eye is done so that eccentric fixation becomes less fixed. Various types of occluders are available in the market. These could be adhesive skin patches made of micropore, commercially available opticlude patches, spectacle occluders, and opaque contact lenses. So the Pediatric group has conducted several ATS studies over the past years. Results have mainly shown that spectacles alone are powerful treatment for amblyopia, but patching is superior to spectacles. Initiating a few hours of prescribed patching seemed to be as effective as the traditional full-time patching. And patching could be effective in older children also, particularly if they haven't been treated earlier. So when to initiate occlusion therapy is the big question. Although it seems very difficult, but it should be best instituted in early infancy because amblyopia is amenable to treatment, and treatment could be highly cost-effective and benefits long-lasting. The protocol for occlusion, as we all know, follows the age-is-to-1 algorithm. In the 0 to 2 years, we occlude the dominant eye for 2 days, followed by the occlusion of amblyoptic eye for 1 day. And so forth for 3, 4, 5, 6, we occlude in the ratio of 3:1, 4:1, 5:1, and 6:1. Beyond 6 years also, we follow the 6:1 rule. So how much patching is required? The ATS have helped to define the role of full-time patching versus part-time patching. In 3 to 7 years with severe amblyopia, full-time patching provided similar results as compared to 6 hours patching per day. And in 3 to 7 years with moderate amblyopia, 2 hours patching was equally efficacious to 6 hours patching per day. In the age group of 7 to 13 years, 2 to 6 hours of patching could improve visual acuity only if amblyopia was previously treated. And in 13 to 17 years of age group, 2 to 6 hours of patching improved visual acuity if amblyopia was not treated previously. So follow-up schedule follows the algorithm of 1 week for each year of age. If a child is 3 years of age, child should be examined at an interval of 3 weeks. If at the time of re-examination, fixation has not improved, we can increase the period of occlusion to double prior to next examination. At each follow-up, we should see the visual acuity if it is improving or worsening, the fixation pattern of the child, and any change in the fixation pattern of the child. The endpoint of therapy is deemed when there is free alternation between the two eyes, there is equal vision between the two eyes, or if there is no visual improvement, even after 3 to 6 months of compliant patching, or after at least 3 intervals of full-time occlusion therapy. However, therapist discretion may come into play if the child is very, very young and not improving even for 6 months, and there is suspicion of compliance issues. In these cases, we can extend the occlusion therapy even beyond 6 months. So follow-up is required even after completion of successful treatment, every 1 to 2 months for infants, 3 to 6 months for the children of 3 to 6 years, up to 6 years of age every 6 months, up till the age of visual maturity. So though it might sound very easy, motivation of children and parents is the key to successful patching. Active vision exercises like dotting O's and encircling E's should be given to the child while occlusion. In case vision is improving, occlusion should be continued not only till the amblyopic eye develops equal vision, but also equal preference in that eye. So compliance issues have always been there with occlusion. With the advent of occlusion dose monitors, it has been confirmed that not all children comply well with patching. The MOTAS and the ROTAS study have shown that compliance with patching averages less than 50% of the prescribed time. So these are pictures of various occlusion dose monitors developed over time. Recommended strategies for facilitating patching could be use of rewards in these children, decoration of the patch, educational cartoons, and establishing a routine with the help of others. Prognostic indicators for good compliance will be parental awareness of the reduced visual acuity at the time of examination and increasing the knowledge of the condition among parents and children. Various near vision activities which require hand-eye coordination should be prescribed to the child during such times. These could be reading, writing, playing with blocks, playing video games, tracing pictures, and puzzles. So the American Academy of Ophthalmology preferred practice patterns now recommends that an attempt of treatment should be given to all amblyopic children regardless of their age, even those including later childhood. So these are a few good prognostic factors in amblyopia. The younger the age, strabismic amblyopia, myopic patient, a good pre-treatment visual acuity which helps in better compliance, good patient compliance, additional near exercises while giving amblyopia therapy, and absence of eccentric fixation. So when do we call it a failure of occlusion? Failure of occlusion is said when there is no improvement in the visual acuity for 3 to 6 months or at least 3 intervals of full-time occlusion therapy. Recurrence could also occur in successfully treated patients in about 1/4 of such children within the first year of treatment itself. The risk factors will be abrupt cessation of therapy, cessation less than 10 years, and strabismic amblyopia. Therefore, it is recommended to taper to maintenance therapy for all children and follow up to 1 year after the completion of occlusion. There could be disadvantages of occlusion therapy also, like occlusion amblyopia, which is the diminution of vision in the seeing occluded eye. It has a very low incidence, it is transient and reverses on stopping the therapy. Functional debilitation could occur in severely amblyopic children, especially early in the treatment, and is a deterrent to good compliance. A cosmetic blemish and peer pressure could occur due to wearing the patches. Allergic skin rash because of the glue on the opticlude patches. Effects on ocular deviation could occur as patching might disrupt fusion, leading to a sensory deviation. So a new onset squint is very distressing to such patients as well as their parents. So parents of children who have no strabismus or microstrabismus should be forewarned that there is a chance of a new or a worse strabismus developing during treatment. The rate of visual decline is variable between 24 to 75%. Various ATS studies related to patching and amblyopia have been undertaken, like the ATS1, 2A, 2B, ATS3, the ATS 9, 10, and 11, and ATS 15 and 17. I will not go into details due to paucity of time. So just to summarize, occlusion is still the gold standard therapy for amblyopia. The early we treat, the better results we get. No child should be denied trial of patching. A good parental counseling is a key to good prognosis. Do not stop patching abruptly. Taper maintenance therapy and follow up even after maximal visual acuity is achieved. Always assess compliance before labeling failure of treatment. Thank you.
Thank you for that wonderful talk. I think very well timed, and you took the topic by, I think, covered everything as far as the traditional patching goes. I would request Dr. Nikhil to introduce our next speaker in the topic, please.
Yeah, so I'd like to invite Dr. Pradeep Deshpande to talk about recent advances in amblyopia management. Thank you. Dr. Pradeep Deshpande?
Not joined either.
Doctor, I think we do not have Dr. Pradeep Deshpande, but we definitely have Dr. Paramita.
Yeah.
So we can ask her to do the presentation.
All right.
Is that okay with you?
Sure, absolutely.
All right, sir.
Dr. Paramita Sanadani for advice to parents of a myopic child, please. Thank you.
Dr. Paramita, you can share your screen now.
Yes, I'm sharing my screen. Okay. So I think it's a common scenario in all our clinics. If we prescribe glasses for even moderately myopic glasses for children, or every time the power goes up, there's absolute haywire. The parents often go absolutely ballistic. So, and I often joke that in the time that it takes me to counsel the parents, my cataract colleagues can definitely perform 2 phacos and enrich their bank account by a significant degree. But jokes apart, myopia is actually a serious issue, and it is time that we took time to try to combat this, because now we know that there are some lifestyle modifications and other modifications which can help to, if not completely halt the progression of myopia, at least to decelerate the progression of myopia. As we can see in this graph, myopia is expected to go up quite a lot by 2050. And with it will the complications that are associated with high myopia, like retinal detachment and degenerations, myopic degenerations. So it's time that we took time to talk to the parents. Now, regarding the advice that we give to the parents, it's basically reassurance. Parents sometimes, they think my child has a -1 at age 10. It's gone up to -2 at age 11 and -3 at age 12. So they do the math and think by the time the child is going to be 25, he'll have a -15. So we need to take time to reassure them and tell them that this is not going to happen. Also, because as I said, that the progress of myopia is to some degree modifiable, we need to tell them what they should do and what they should not do. The first thing that almost everyone asks is there anything we can do to stop the increase of myopia? If they had asked me, say, 10, 15 years ago, I would have said, sorry, there's just nothing we can do about it. But now we all know about the ATOM study, and we all know that atropine 0.01% does have a significant effect. Now, this ATOM study has been done to death, and I'm not going to go into that, and especially because Dr. Shukla is going to probably deal with it later. But I do use this graph to explain that using atropine will not stop the progression of myopia, but it will slow down the progress. And the problem with atropine is not that the parents don't start. The parents started very well. The problem is compliance. What happens is we generally advise atropine and review 6 months. And then for some reason, now COVID, they don't come in 6 months. They come maybe a year later, maybe even a year and a half later. And they say that they have used atropine diligently for the first 6 months, and then they stop because we had said for 6 months. So I think it's important to explain to the parents that atropine goes on. If you can't come, the atropine continues. The other things we need to tell them to do is that they must have a yearly eye checkup. And of course, all children need to come immediately if they have an eye injury, but myopics even more so, myopic with peripheral degenerations even more so. And also we need to alert parents to the symptoms suggestive of a retinal detachment in myopic children, especially those with PRD or those with a family history of retinal detachment. The other thing, this we never had to say. In our childhood, parents had a lot of trouble bringing us back indoors. But now getting the children to play outdoors is not common anymore. So we need to, and there are a number of studies that have shown that outdoor activity does delay the onset of myopia, and it does also diminish the rate of progress of myopia. So we must tell the children that, the parents mainly, that they need to encourage their children to play outdoors. During COVID, this is not so easy, but what they can do is maybe play on the veranda. We also have rooftops in India. They can go and play outside as much as possible. What not to do. There are not many things that I'll say you shouldn't do. One is, if you have a PRD, if you have a family history of detachment, go easy on the contact sports. There are lots of other things you can do. And this is the main problem. Again, studies have shown that increased dependence and increased use of digital devices is causing an increase in myopia. And the problem is that in COVID, we can't do without our digital devices. This conference is virtual. The children have to go to online schooling. But what we need to say is that apart from the amount that they have to do, maybe they should cut down on the recreational use of digital devices. Like I often have some mothers of babies who will come and say that they use the mobile while feeding the child. Otherwise, the child will not feed. So I think we should avoid that. And some studies have shown that while the pandemic will go, schools will reopen, this habit that the children have gone into of relying on their digital devices, this will take time. And we need to educate parents about that. So thank you very much for listening to me. And I'd also like to thank my assistant who has helped me prepare this presentation and stayed with me throughout. Thank you.
Thank you, ma'am, for that very informative talk on the next pandemic, which we all expect by 2050 with myopia, and also to help us get out of those difficult questions that the parents ask. I would request Dr. Nikhil to introduce our keynote speaker.
Thank you, Dr. Aditya. Yeah, I would like to request Professor Yogesh Shukla to come and enlighten us about myopia in children, please. Thank you.
Dr. Yogesh, you need to unmute yourself, please.
Now, can you just help me to put my presentation on the screen? I just forgot.
Sure. We'll take you through. Doctor, if you see at the bottom, you'll see a green icon.
Yeah, share screen. Yeah.
And there's a small...
Can you talk a little loudly, please?
Yeah, there's a small little arrow next to it.
Yeah.
Not the green arrow, the white arrow.
I don't see a white arrow here.
Which is a pop-up. Which is a pop-up basically. When you just click share screen, you'll get a lot of different options to select your file.
Just a minute, it has gone back, just a minute.
Yes, sir. Did you click on share screen?
Just a minute. Oh, it has gone up. Yeah. Now, see what I am getting on the screen is.
Bottom, sir, there'll be a green button called share screen. You can just click
share screen.
So when you click that, you'll have three options on the top: basic, advanced, and files.
Yeah, basic, advanced, and file. Yeah.
Try to click on files.
Okay, files.
And see where you have stored your file.
Yeah, it is on the desktop.
Okay. So what you do is,
it is on the desktop. So how do I go there?
Sir,
it is on my computer on the desktop.
First you need to open your presentation.
Yeah, that is open.
You need to open, yes.
And I think
minimize your presentation, then go to share screen.
My presentation is already open,
So just click on basic and you'll see your presentation there and double click on it.
Yes, sir. Yes, sir.
Just click on basic.
I add a share screen again and go to the basic. Okay.
Basic. You'll see your presentation there. Can you see that PPT?
Yeah. I saw it.
Yeah, click on the PPT, sir.
Click on the PPT.
And say share. Yes, perfect.
It has come?
Yeah, it will upload in a moment.
Yeah.
Yeah, it has come and you can now go to full screen.
Full screen is 5. I put it. I can speak like this also.
At the bottom of your presentation, right side corner, there is a cup sign. Glass sign.
This one? No.
Where is your mouse?
Sir, the sign
down.
At the bottom,
yeah,
you have an option to enlarge your screen.
Yeah, so where is that?
Sign.
This one?
On the right side bottom.
So you can press slideshow on top also and you get it.
Yeah, you can also press slideshow on the top.
Just under your title. File, home, insert, design, slideshow.
Slideshow, okay.
Click on that and save from beginning.
The first option from beginning.
Oh, single click, sir, on slideshow.
Sorry, what is?
No problem, sir. Go back to slideshow. File, home, insert, design, translation, animation, and slide.
Yes,
Yeah, click that.
slide.
Then go to the first option from beginning.
Okay.
Okay.
Did you? Yes, sir. You're on now.
Yeah. So now, good afternoon to you all, and speaking in very short, the nature and management of myopia. You see, just I'll give you a brief account of the prelude for the myopia, which is the basic of all the work we have been doing for so many years all over the world. See, myopia is the most common refractive error and so prevalent that it has attracted the maximum studies worldwide. A recent study by National Eye Institute USA showed that the incidence of myopia in general population has grown from 25% to 45% in the last 1 decade. Nearly 100 million children and 1.5 billion people worldwide are myopic. And it is estimated that in the next 10 years, persons would be 2.5 billion. And that is half of the world's population would be myopic in the next 10 years. So you can see the menace and the magnitude of myopia, which is now going to come forward. Now, looking at the worldwide figures, a whopping 90% exist in the Asian countries like ours, 30 to 40% in America, and only 10 to 20% in African countries. There's a reason for this. I'll tell you later on. Now, since myopia is such a massive public health problem, efforts to control its progression have been futile. And because of that, it has generated the maximum interest regarding the pathogenesis and the methods to control myopia. Now, we have to first understand the pathogenesis, the etiopathogenesis of myopia before we can have the modes of its containment or modes of its correction or modes of management. Now, these are some of the points which have come in the last 2 decades of massive research which has gone all over the world. Now, the main salient features which have come forward is hereditary, nutrition, near work and accommodation, biochemical changes, outdoor activity, refractive correction, seasonal variation, and illumination. Now, out of these, the hereditary is the most prominent factor which has come out in the causation and the progression of myopia. Now we have so many, almost there are about 200 genes which have been found, which in some way or other affect the causation and the progression. I'm not going to detail because that's not important for us. Nutrition, almost every nutrient has been, has been indicated to be a cause of progression of myopia. The most important is vitamin D. The research now is showing that persons or children who have deficiency in vitamin D are more prone to the progression of myopia. Near work. Of course, near work has gained a lot of emphasis now, and the near work which is now we are doing in excessive because of naturally more and more people are engaged in the last 1.5 years on the laptops and computers and other gadgets. See, peripheral defocus, hyperopic defocus, visual deprivation, and accommodation. These all factors combine together to cause the progression of myopia. Now, we don't have time because this is a topic which is for last, when I last year and when I put it for half an hour master this thing, but we can't go into details. Anyway, biochemical changes. Human sclera is fibrous in nature, consisting of 75% of collagen type 1 of dry weight. The extracellular matrix consists of proteoglycans, glucose, aminoglycan, and deficiency of these amino acids. Now, deficiency of amino acids like thiamine and lysine have been reported to be a cause for the progression of myopia. Now, there's a lot of things, how these, these amino acid and proteoglycans help in the formation of the collagens. And if they are deficient, the collagen become thin, they are elongated, they lose their tensile strength, and they are susceptible to the progression of myopia, the enlargement of the eyes at the posterior pole. So then biochemically, let's skip this, not important. This is also not important. Now, the modes of management. We have seen all the factors which have been found to be prevalent for the causation of myopia and the progression. Now, how do we control myopia and its progression? Now we have these 5 things in our armamentarium, spectacles, bifocals, contact lenses, which are now recently used as the defocus contact lenses, which are known as disc lenses. Then environmental conditions, pharmacology reagents, and orthokeratology. Now, because of the paucity of time, I'm not going to go into the details of all those, what are disc lenses and what is orthokeratology. 3 main factors have come in our light, or it has come in our research for last 2 decades, which have been major impact, which create or cause a major impact in the causation and progression of myopia. One is environmental, second is near work, and third is the pharmacological agents, which we can use to control the progression of myopia. Now, the first and the foremost is the environmental factors. Now, how does environment help us? See, the human eyes, which have evolved over millions of years, were not programmed to do so much of near work. They were meant to see for distance only, as people were mostly wanderers, farmers, and roamed over mountains and pastures. So, the architecture of the eye was not programmed to do so much of near work. Now, near work has, it involves all the extraocular muscles, the accommodation, the illumination also, and all these have an impact. The exact mechanism of how these factors cause the progression of myopia we do not know yet, but the research, the experiments have shown that because of all these, the myopia progresses more strongly. Now, coming to the same factor as environment, it has been shown by research that 1 hour of outdoor activity contraindicates 6 hours of near work. That means that if you are engaged for 6 hours of near work, reading or writing or computer, whatever it is, and if you compensate that with 1 hour of outdoor activity, that would nullify the effect of the near work on the progression of myopia. This is a fantastic research, and the people are still trying to work on more of it. Then near work and accommodation. This is another area where we can control the near work. Long hours of near work, stress on extraocular muscles have known to cause the progression of myopia. Excessive accommodation has been also known to cause the progression of myopia by release of certain chemicals, neurotransmitters, which have been shown to progress the myopia. So if we can control this, we can control the progression of myopia quite an extent. Then the third thing in our armamentarium, where we use to treat and control the myopia, are pharmacological agents. Now, the most important pharmacological agents, now there are various pharmacological agents which target on different areas of the eye to progress, because the retina, the sclera, and the choroid, they all contribute to the progression of myopia. So there are drugs which are targeted for special. Now, drugs targeted for scleral therapy. We have atropine, number 1. All has been tried, 1%, 0.5, 0.1, and now 0.01%. 0.01% atropine is now the most popular drug in our pharmacological agents to control the myopia. It acts on all the 6 we have M1, M2, M6, M5, and 6. up to M6 receptor agents. It acts on all the factors, but atropine 0.01 acts only on the M1 and M2 receptors, which are in the retina and sclera, and they control the the progression by controlling the dopamine and acetylcholine release, which causes due to stress. Pirenzepine is another drug which comes as 2% ophthalmic. It acts specifically on the M1 only, and thus helps in our control of myopia, acting on the retina and the sclera. Methylxanthine, not available in India, also is an M1, M2 receptor blocker, and it can be used like this. Nutrient supplement. As sclera is mostly collagen, various nutrient supplements have been advocated to strengthen myopia, especially vitamin A, vitamin D, and vitamin C. Surgical endeavors. This is another way. Cadaveric scleral implants have, give me a minute please. Cadaveric scleral implants have been used, but it has been outdated now. Collagen cross-linking has been done like cornea, and biopolymers have been used as a scaffolding on the posterior sclera to control the posterior pole elongation. I think we stop here, and thank you very much for the patient listening. Okay, thank you.
Thank you so much, sir. I think we have time for some questions. We have about 5 minutes before the session ends. So if you have any questions for any of the speakers or Dr. Nikhil, any questions or attendees, you can just type in the chat, we can ask them.
No questions as such. I think Dr. Ramesh is also here now. I think it was pretty well covered. A variety of topics was there. It's very difficult to cover so many topics in that much amount of time. But I think every speaker did a great job. So it was very relevant the way the refraction was covered and how much to prescribe, when not to prescribe. These are the important points that were nicely covered. Amblyopia patching, very, very important. But I do believe that, yes, we have to look at the amblyopia treatment studies with a pinch of salt, because those settings are different. The compliance is much better out there. I'm sure Dr. Aditya, Dr. Ramesh, you will agree with this, that they have taken into account that the compliance factor was very good when they did the ATS studies. We cannot really depend on that and rely on that so much. So especially in the dense amblyopes, maybe the 3/60 monocular amblyopias, I really do believe that part-time occlusion is not really going to be useful, because the brain is really going to still ignore for the remaining waking hours. It's going to ignore the amblyopic eye. So I think you need to look at it with a pinch of salt. So excellent topics, and myopia is such a relevant topic. It never ends. It just goes on and on. But yes, atropine is something that good that has come to us. It's a very important tool in our armamentarium.
Dr. Nikhil, we have Jitendra with us. He has done a lot of work.
Yes, I know.
And
Jitu Bhaiya, namaste.
Yeah, just let me complete. And we have, shared for many years the podium. And I have been also working on atropine 0.01 for almost 5 years now, and the studies are there. The myopia, the treatment for myopia is still evolving. It's still evolving. We're going to have newer drugs, and as we know, the more neurotransmitters which are present and which are released due to stress, like what I told you before, like the accommodation and the stress on the extramucus and all these. So many neurotransmitters like dopamine and acetylcholine are releasing. We're going to have specific drugs which target those True. And 0.01 atropine has come out, very well for it's only one of the drugs which has not come out. But we are trying to, target the exact area where the neurotransmitters come out to, to create the progression of myopia and post-myopia. Jitendra, do you have something more to tell us about? Because, as I told you, myopia in next 10 years is going to, half of the world is going to be myopic in next 10 years. Half of the world. So,
Dr. Jitendra, what are the results that you're seeing in your part of the country? And do you think that it's really working well, atropine?
Yeah, I think it is. Since we have woken up to this pandemic of myopia, I don't think we would end up having 50% of the people having myopia, because now we have already sent it for review in IGO. We have inline a publication on pre-myopes. So we have now been able to define pre-myopes, and I think that would be a good time to intervene, since we know that 50% of the people are going to become myopic. So that would be another interesting thing. Pandemic, we already submitted our work on the non-responders secondary to pandemic, and we have done some work on, we randomized our patients on twice a day dosage versus single day dosage. That is, we have not submitted it, but we will be submitting it soon. And we feel that, at this point of time, whatever work is being done in the country is based on once a day usage for atropine. And I'm using, and I would be presenting the data in next couple of days in myopia masterclass. And we have an IC with Dr. Shruti on myopia. Query is part of that IC. And so I would be presenting our data on the fact that we should now switch on to using these drops twice a day, because at least in a small RCT which we did, we found that twice a day was more effective than once a day. Children who are non-responders, at least 30% of them in the pandemic, at least 30% of them did respond to 0.01% twice a day. So at least you can get a coverage of 30% more people when you use it twice a day. The basic issue, as the Shukla sir said, the basic issue is that we still do not have good biomarkers which can, quickly give us the result whether this particular drug is working or not. And we have to wait for a couple of years before we can say that yes, twice a day is working or once a day is working, or head to head. So multiple people have to do this at multiple places to do different things. As a private practitioner, I don't have a huge number of patients. I think Ramesh and they have set up a separate. They have got a myopia scientist with them. I think Pawan is working a lot on this, and they are coming up with a lot of new things. Your experience, Ramesh?
Yeah, quickly, time is not much, I think here. I totally agree with you, Jitendra. One of the thing I am experiencing is 0.01% once daily does not work in all the patients. Next step is to go to make it BD. The next step is to increase the concentration. And in little bit older kids, I feel orthokeratology works better. In the next few months, we are going to produce our own ortho-K lenses, which will be available for all of us to use. So that is one option. And Pawan is doing a lot of other factors, as you said, biomarkers and the nature, all that we are trying to study thing. For a practitioner, I just wanted to give one tip is that one time may not work in all the patients. And it does not work in each and every. I see some of the practitioners giving in anisometropic amblyopia with -9 in one eye and maybe 0 in the other eye. It does not work there. So there are some of the things we need to take care. Because of the time factor, I don't want to prolong the discussion. I would like others to speak and their experience. Thank you so much. I could not connect earlier because of the linkage issues.
Do you have a minute, Hima? Do you have a minute?
Yes, sir. We do have 1 minute.
See, one thing more. I'm in touch with Dr. Miho Sato. She is one of the professors in Japan. Jitendra also knows her. She had come here to India in one of her SPOSI conferences. See, they have banned mobile in. What I was going to tell you, when you saw the 90% in the Asian countries, East Asian countries, 50% in US and Europe, and only 10% in Africa, because those people are not engaged in near work in Africa. They have been mostly wanderers and leading a nomadic life and all that. So near work as a natural treatment, near work, avoiding near work is a big would be a boost for controlling of myopia. And it is now, a lot of people are in India. I don't know if Jitendra is doing it or not, but a lot of people are, they are, as also there have been reports from our institution, medical college also, because of the pandemic. And with COVID, that people who have engaged, it was in the papers also 3 days back, I was reading in Times of India, that because of the pandemic, the ocular asthenopia and the number of glasses have increased. The All India Institute RP Center also conducted a study. So one thing I want to stress is that you should always tell the children, avoid mobile, at least mobile. And as I told you, for 6 hours, 1 hour outdoor work is would contradict, would counteract the the strain what you get from mere work. So these are certain natural things which can use, which we can still use. Twice atropine, I agree, and 0.05 atropine is also now in the vogue. Some people are trying to do it 0.01, 0.05. So the things are still evolving. We are in the we are in the ship where a lot of people are there. We have a lot of ideas and views, and because myopia is a pandemic, it's going to be a pandemic. It's a big health hazard in the future to come. So the younger people should come and do it. We have shown the way. Jitendra and Ramesh, you're all younger people. You should come with full force for this myopia. And thank you very much for giving.
Dr. Shukla, can I make a 10 seconds comment or?
Sure. I am not the
Dr. Shukla, I completely agree with that near work point. Here, when we examine children at the tertiary care center, the myopia incidence is very high. When I go twice a week to the secondary center, I don't see any myopia at all there. That's already a thing. I just wanted to add that near work really plays a major role. Second thing is outdoor activities you brought up. This works more in pre-myopes than myopes. Pre-myopes, if you want to prevent, that is where it works. Once the myopia sets in, the chances of increasing outdoor. I'm not saying we should not encourage, but it does not help much there.
No, it is not my study. It was a study from the papers. That's why I put it that 6 hour counteract, 1 hour outdoor would counteract 6 hour activity. And if it is 8 hours, you put it 2 hours. If it is 10 hours indoor, you make it 3 hours. It's like that.
All right.
Thank you so much.
Okay, I would like to take this opportunity to thank all our chairpersons and all our speakers for this wonderful session. Thank you so much for joining in. And
thank you.
Thank you, everybody. And nice to talk to you, Ramesh. Seeing you after a long time.